Neuro Ophthalmology questions by Dr. Zeinab Ahmed Saad. This is a fundus photo of 2-year-old male patient complaining from strabismus. What is the name of this congenital optic nerve anomaly? What is this sign called? In this case, what endocrinal abnormality would be suspected and which laboratory test would you order? This is an optic nerve hypoplasia, and this sign is called double ring sign, in which the outer ring represents what would have been the normal disc margin. This condition may be associated with de Morsier syndrome and midline developmental brain defects with endocrinal abnormalities and hypopituitarism, especially with low growth hormone levels. An relative afferent pupillary defect associated with normal visual field is most likely seen when which of the following structure is damaged: Edinger vestibular nucleus, brachium of superior colliculus, recurrent nerve of Arnold, anterior knee of von Willebrand, posterior pole of the occipital lobe. The right answer is brachium of the superior colliculus. Causes of RAD is massive retinal damage, asymmetrical optic nerve affection, chiasmal lesion, proximal optic tract lesion, and lesion in pretectal area. And this is the only one lesion in pretectal area which is associated with normal visual field, and lesion in brachium of superior colliculus caused the contralateral RAD, and hence there is no visual pathway involved, so visual field defect does not occur. A 22-year-old female patient suffering from known Graves' disease, autoimmune disorder in thyroid gland. She noticed left upper lid drooping. What would you do? Frontalis slings, glasses with crutches, ice pack test, or levator resection? The correct answer is ice pack test. Why? Because Graves' disease, which is autoimmune disorder, may be associated with another autoimmune disorder, which is myasthenia gravis. And we should know that when thyroid eye disease is associated with exotropia or ptosis, myasthenia gravis must be suspected. And keep in your mind that thyroid eye disease, 1% of patients of thyroid eye disease have myasthenia gravis, and 5% of patients with myasthenia gravis have thyroid eye disease. 18-year-old female patient complained from limitation in up gaze and lateral gaze. Also, she complained from bilateral symmetrical ptosis. What is your initial diagnosis? How would you confirm your diagnosis? Which investigation would you do first? Ptosis is almost always asymmetrical, while bilateral symmetrical ptosis is only 3 conditions, which is blepharophimosis, third nerve palsy of nuclear origin, and chronic progressive external ophthalmoplegia. And this is a case of chronic progressive external ophthalmoplegia, which is Kern-Sire. To confirm my diagnosis, I would do blood sample, biopsy from muscle, and lumbar puncture. Which investigation I would do first is ECG, as Kernicere is associated with heart block, and this may be life-threatening. 75-year-old male patient complained with acute onset of diplopia. Examination of the patient revealed third nerve palsy. Which investigation would you do first? How would you confirm your diagnosis? When would you start treatment? So, any old age with central retinal artery occlusion, branch retinal artery occlusion, diplopia, third nerve, fourth nerve, sixth nerve, transient ischemic attack is giant cell arteritis until proved otherwise. So investigation to do first is erythrocyte segmentation rate and C-reactive protein, and I would ask him for any jaw claudication or transient ischemic attacks. And then how to confirm my diagnosis? I will confirm it with temporal artery biopsy. And then I will start treatment at once. Don't wait for results of investigation as to prevent any affection of the fellow eye. There is a fundus photo here of an anomaly of the optic disc, and ultrasonography here, and a photo of a CT scan. What is your diagnosis? What are the associated conditions? And what are the possible complications? This is an optic disc drusen showed in the photo here and in the ultrasonography here, while lowering the gain as it is a calcification of the optic disc, and also it is shown here in the CT scan. This condition may be associated with retinitis pigmentosa, angioid streaks, and Usher syndrome and other syndromes. What are the possible complications? The most common complication is juxtapapillary CNV, choroidal neovascularization, and also anterior ischemic optic neuropathy. In idiopathic intracranial hypertension or pseudotumor cerebri, all the following findings would be expected except bilateral sixth nerve palsy, papilledema, headache, tinnitus, and elevated cerebrospinal fluid protein. The answer is elevated cerebrospinal fluid protein, as idiopathic intracranial hypertension may be associated with bilateral sixth nerve palsy, papilledema, headache, and tinnitus, and also may be associated with elevated pressure of cerebrospinal fluid, but with normal protein with normal protein level in cerebrospinal fluid. This is a fundus photo showing an anomaly of the optic disc. What is your diagnosis? What complications should be considered? And what are the possible associations? This is a morning glory of an optic disc. Complications should be considered as serous retinal detachment and CNV, adjacent CNV to the optic nerve, juxtapapillary. Possible associations, it may be associated with neurofibromatosis type 2, phase syndrome, which is a posterior fossa brain malformation, and frontonasal dysplasia with basal encephalocele and Church syndrome. Vertical nystagmus occurs in phenytoin toxicity in an unconscious patient, suggests thalamic lesion. Upbeat indicates cerebellar tonsillar ectopia. Downbeat indicates a lesion in the bones. Right answer is vertical nystagmus occurs in phenytoin toxicity. And you have to know that unconscious patient of thalamic lesion may suffer from down deviation of the eye, and downbeat nystagmus may be associated with Arnold-Chiari malformation syndrome. A 30-year-old female patient. Examination reveals limited adduction in both eyes and nystagmus on abduction in either eye. Pupil examination revealed a right afferent pupillary defect. What is your initial diagnosis? What investigation do you want to do first? My initial diagnosis is bilateral internuclear ophthalmoplegia associated with previous optic neuritis, as there is abnormality in the pupil, which is right afferent pupillary defect. Those associated together with a young female. So multiple sclerosis is suspected, and the investigation to do is MRI brain to search for periventricular plaques.